morning, everybody. Thank you so much for joining us today. We have some important information we wanted to share. I'm sure a lot of you have heard that nationally there are some trends happening across the country where people are holding back on their health care because of concerns related to the pandemic. So there are some national trends, and that caught the attention of our leaders here. So we've been tracking that, and we have discovered some interesting local trends that are concerning to our physicians. And so we wanted to share those with you today, and also hope share our message that we're safe, we're open, we want people to come back and get their preventative care and any kind of health care they need that will help prevent bigger problems from happening later. So with us today, we have Dr. Russell Vinnick, who's our Chief Medical Operations Officer. He's going to say a few words, followed by Sandy Gobranson, who's our Chief Quality Officer. Sandy has some data that she's going to share with you, some of the data that I talked to you about. Also joining us is Dr. Sachin Apte. Dr. Apte is with Huntsman Cancer Institute. He's the Chief Clinical Officer there. He's also Professor of Obstetrics and Gynecology with University of Utah Health. And we have Dr. Jose Rodriguez, who's a Professor of Family Medicine at University of Utah Health. He's going to be talking to you about some of his concerns related to this today. And also Dr. Rodriguez is available to answer questions in Spanish at the end of the press conference. So we're going to start right now. I'm going to just pass it over to you, Dr. Vinnick, to open the press conference.
Thank you, Kathy, and thank you all for joining us. We follow a lot of data, and we've been following a lot of data since the beginning of COVID to track how this is affecting our patients, and not just COVID, but also other conditions. And a disturbing trend that we've been noticing over the past almost year now is a significant reduction in care and preventative care. We've seen on a national perspective, particularly at the height of COVID, there was an 80% reduction in colonoscopies, 40 to 60% reduction in childhood immunizations and mammograms, and also a significant reduction in other preventative care. We've started to see that those numbers are improving, some in more areas than others, but this is still very, very concerning to us and to me as a physician. We know that cancer, when caught early, can be much more easily treated or even prevented. But we don't want to be in a case where we're treating a community with advanced disease that potentially could have been treated earlier if we had gotten that preventative care. So we've seen this on a national level. And then Sandy, my colleague, is going to talk about some of the data we've seen within the University of Utah. And then we'll talk a little bit more about what we can do moving forward.
Thank you, Dr. Vinnick. The first slide shows our breast cancer screening rates. And as you can see, they've declined about 4 percentage points since March. Next slide is our colon cancer screening rates.
Hang on, just one second, Sandy. We're having we need just a second to pop up the screen. Give us just a second. We'll go to that first screen you were referencing. Sorry about that, folks. Give us just a minute here. I just go to 2, Sue. Yeah, there you go. All right, there we go. Okay, let's go back to that first screen, Sandy. Thanks, sorry about that.
No problem. So as you can see here, our breast cancer screening rates have declined, like I said, about 4%, a little more, since March, from our baseline. Next slide is the colon cancer screening rates. Just waiting for the slide to advance.
Just a second, folks. There we
go. And as you can see here, the decline isn't as steep. It's about 2 points, but that's in large part due to the timeframes of colon cancer screening versus breast cancer screening. Colon cancer screenings are 5 to 10 years versus a year to 2 years. Next slide shows our hemoglobin A1C testing for diabetes control. And as you can see, that's a fairly precipitous drop of about 7%. Next slide is our childhood immunizations. And while you can see an early drop, it has recovered a bit, but that does not take into account all those kids we missed during those times when we weren't up to baseline. So that is also a concerning trend. And I'll pass it back over to Dr. Vinnick.
So thanks, Sandy. And so as Sandy has shown you, these trends are concerning. We are starting to see some improvement in some areas, but realize that our populations, our citizens, have gone many months delaying or potentially not getting care that they've needed. And so that can lead to bad outcomes. People who don't get their diabetes or blood pressure properly controlled, that certainly can lead to heart attacks. Cancer screenings, we obviously know, are effective at either preventing cancer or getting it caught in early stages. And childhood immunizations. The last thing we need as we're battling this COVID pandemic is to have another outbreak with something easily preventable like measles. So we strongly encourage the public to get the care that they need and to take care of themselves. We've seen national data where a lot of people have expressed concerns about the safety of visiting their doctors. And I want to address those about what we are doing to keep our patients safe. So first, we have vaccinated almost all of our clinical staff. At least 80% of them have gotten 2 vaccinations at this point. Second is we have cleaning protocols throughout the hospital to ensure adequate safety as well as airflow. Third is we require a mask of all of our patients who enter our hospitals or clinics, as well as every single staff person while they are indoors and around other people. We also have data. We at the university, we see over 90,000 patients in person per month. Over the past 11 months or so, we have had a handful of cases that we may be able to attribute to either provider to patient transmission or possibly patient to patient transmission. And those were early on in the pandemic as we were starting to learn more and more. So we have learned a lot during this COVID time about how to keep ourselves safe and our patients safe. And we strongly encourage the public to get the care they need. Don't delay it, because delayed care can often lead to very bad outcomes. And we're here to help, and we want to be able to treat you and take care of you. So please come. Certainly for the public, if they have concerns about seeing a provider in person, we have virtual visits available, and virtual visits have been fantastic throughout this pandemic. They've allowed us to contact our patients when we had no other way, but then recognize virtual visits can't do everything. Things like preventative screenings, blood tests, hemoglobin A1C, diabetic eye exams, those just can't be done virtually. And also sometimes, I know as a doctor, sometimes those very difficult and complex patient discussions that you need to have and need to be able to have a good dialogue back and forth, they can be very difficult to be done virtually. So we encourage the public to come in. Certainly, if they have concerns, virtual is an option, but in general, we can do more and we can accomplish more screening and testing at an in-person visit. And if somebody has concerns and really just doesn't know, should I come in or should this be virtual, call us. Our staff is trained to help walk you through that based on your symptoms and also what your doctor recommends. So, in sum, we've seen some concerning trends. We believe that we have the capacity, and the public just needs to be assured that the hospital is safe. Don't delay your care. COVID is not over, but it's also on the side, and we have learned how to manage COVID. So please, please, please get the care that you need.
Thanks so much, Dr. Vinnick. And thank you, Sandy. We're going to open up to questions. And while we're waiting for the questions, please send your questions through the chat feature. I'm going to turn over to you, Dr. Apte. When you're seeing some of these trends as they relate to cancer screenings, tell us about some of your concerns. What is happening when people are putting off colon cancer screenings, mammography, blood work that they might need? Tell us how you're reacting to some of that data.
Sure. First, thank you for this opportunity. As an oncologist, I think such venues are so important for us, the physicians and oncology community, to directly interact with the community that we treat. When I see those trends, when I see the trends that were just presented, whether they're from our health system, University of Utah, or broader nationally, they kind of mirror each other. And when we know in the world of oncology that screening works, mammography, colonoscopy, screening for things such as cervical cancer, lung cancer, prostate cancer, these things work. They've been studied over many years, and we know that they save lives. And certainly catching a cancer before it's a cancer, or if it's a small cancer before it becomes larger, not only can it save lives, but really reduce side effects of treatment and the amount of treatment you require. So when we see trends like this, they are very concerning. We can understand why, COVID has certainly impacted so much of what we do. And I think that, for example, yesterday, many of us have probably seen in the media that about 500,000 Americans have lost their lives to COVID. That's a very startling number. It's a tragic number. But when we think about 500,000, I think it's also important to remember that a little bit more than that, about 600,000 Americans die every year from cancer. I think we all hope that soon we can start taming this pandemic and at least learning to live with it and moving beyond it. And after that, unfortunately, cancer will still be there. And there are many cancer communities that are concerned about perhaps even some spikes in cancer-related deaths as a result of the pandemic. So to echo what Dr. Vinnick said, we have taken the steps that I think we need to, that are necessary to keep the system safe for patients to come out. But I would strongly recommend that patients see their doctors and resume the screening that they may have put off or rescheduled, and really not to skimp that, because we really want to catch these problems before they become much bigger problems.
Thank you, Dr. Apte. Dr. Rodriguez, I'm going to throw a question out to you. Do physicians predict a rush of patients after the pandemic to make up for lost time?
Well, thank you, Kathy. That's a great question. I'll tell you that in my personal practice at Redwood, what we're actually seeing is that people are still staying away. And so I think the message here is that start making appointments. In the past, we had to do, the problem is that we've sent some conflicting messages, right? Because we said, listen, don't come, do everything virtually because we're still trying to get a hold of the pandemic. Now we have a hold of the pandemic. So start scheduling your appointments and come in. And it's not like we predict that a lot of people are going to rush the clinic, but we really hope that people will start calling and making appointments for routine care, which is, we looked at the data, A1C, breast cancer screening. These are things that are done routinely, and they went down specifically because we had to go to a virtual platform. But now we don't have to be there. We figured out how to be doing that in a safe way in person. I think that's the message here. And if a lot of people start calling and needing care, our system will adjust to make sure that they can be seen. Right now, our capacity is far exceeding the demand, and we would like to change that.
Thanks, Dr. Rodriguez. Dr. Vinnick, here's a question for you. University of Utah Health has canceled some appointments during the pandemic over concerns of in-person visits. Are we still doing that? And are we saying that delaying care is a problem, but do we think in-person visits are in any way contributing to the problem?
Yes, great question. And I think that is true. Early on in the pandemic, we did have to cancel or reschedule some visits because we were getting everything together. It took quite some time to get all the PPE, all the protocols together so that we could ensure our patients were safe. That isn't the case anymore. We are very much encouraging patients to be seen in person whenever possible. I was on the news and I did admit there were times when we did have to reschedule elective procedures because our hospital was so full. And that happened. The good news is that has not happened in probably 2 months now. We peaked at having over 80 COVID positive inpatients in this hospital. Right now we're in the 25 range. We have much more capacity. The leading indicators suggest that things are going to continue to improve at least for the next few weeks, hopefully next several months. And so we do have that capacity. And so our message is come get the care you need. Don't delay necessary care.
And Dr. Vinnick, a little bit of a follow-up to that. In the earlier days of COVID, many elective surgeries were canceled. Have we caught up to all of those?
It's hard to say, have we caught up to all of the canceled surgeries? We certainly have been able to schedule anybody who wants to have a surgery, but what we've seen is patients are staying away, and we don't really know why exactly are they staying away. We know some national data that suggests that they're scared, and that's what we want to bring you some data which shows the safety. We also know that there's a lot of other factors that are in play here. Some people have lost their jobs, some people have lost their insurance, and that makes it very difficult. We're here to help and take care of you regardless.
And then another quick question for you, Dr. Vinnick. Can patients ask to be seen by a provider who has been vaccinated?
Ooh, that's a really good question. We, by our laws, are not allowed to ask our providers if they have been vaccinated. And that's a national law. That may be changing over time. Currently, the vaccine is not fully approved by the FDA. So we highly encourage our providers to be vaccinated. Over 80% of them have been vaccinated, but we cannot mandate that of our providers at this point in time. When and if the FDA grants full approval to some of the vaccines, that likely will change. But for the time being, we cannot ask that specific question to our providers and base treatment based on our providers' vaccination status.
Okay. Dr. Rodriguez, should people wait until they're fully vaccinated before they come in and get care? Or should they come now?
Great question. And the answer is, I think that the time for delays has passed. And we don't have to wait for full vaccination to come in. It's safe to come in. So I think what we want people to do, and I think that this has to do with our futures, is to get that routine care, get those mammograms and those pap smears and those colonoscopies that, you know, that were canceled last year or that had to be moved last year. Now it's okay. We can protect you. We can basically say with pretty good evidence behind us that you're not going to get sick from us and you're not going to get sick from other patients coming in to see us. So it's not time to delay anymore. It's time to put on a mask and come in.
Thanks, Dr. Rodriguez. Dr. Apte, I have a question for you. We have heard recently that if you're getting a mammogram and you're about to be vaccinated, that perhaps you should wait several weeks until after your vaccination or get your mammogram before your vaccination. Can you clarify that for us, Dr. Apte?
I think, you know, a couple factors to consider. It is true that it's possible that if you get a screening mammogram, meaning a patient who has no symptoms, no actual concerns, a true screening mammogram, it's possible that you may get some enlarged lymph nodes on the side that you got your shot at. That's just how the vaccine works. For those of us who've been vaccinated, and for those of you who will, you know, there's an immune response and that's your antibodies, and that's your lymph nodes and your immune system working. So that's not a bad thing, but it is possible that it could cause what we call a false, a false reading where a lymph node is enlarged, but it's because of the vaccine administration, not because of a cancer or a precancer. So having said that, I think if a patient is to undergo a mammogram because of an actual concern, let's say a lump or a finding, or if it's what's called a diagnostic mammogram, meaning it's being done because of other abnormal findings, I would recommend that those patients certainly speak to their doctor about it. But in general, I would not recommend against delaying that type of mammogram. If it's truly a screening mammogram, again, a patient with no complaints, no physical findings, and it's truly just screening, I think it's useful to talk to your doctor about the timing of it. For example, you may want to time it such that your mammogram is about 4 to 6 weeks after your injection, after your second injection. But certainly, even in that delay, in those situations, I think it'd be reasonable to consider a delay, but of course, not to forget about it, to make sure you still have that screening mammogram performed.
Thank you so much. A question, Dr. Vinnick, for you. Do we think that turning patients away, the person asking the question here says he's aware even as of just a few months ago that we've been turning people away. Do we think that we helped contribute to this problem, Dr. Vinnick?
Yeah, I think that's a good question. It's a fair question. Did we contribute to this problem? And the answer is yes. We had a pandemic. We had to manage that pandemic first and foremost. And as with this pandemic, one thing we've learned is you have to be nimble and you have to be ready to change. And what we've seen over the past couple of months now is a significant improvement in COVID. And so our message is changing and it's evolving because, once again, heart disease, cancer are now the top 2 killers in the United States as well as the state of Utah. And we need to think back to the basics about what we can do to take better care of ourselves.
Thanks, Dr. Vinnick. Are we seeing insurance companies no longer covering telehealth, Dr. Vinnick?
Good question as well. To my knowledge, I believe insurance companies are still covering telehealth. Certainly Medicare is. I don't know of any insurance companies that are not covering it at this point in time. That could change, but for now, we continue to offer it. We understand that some patients can't come in, some patients are afraid to come in. That is certainly an option for you, but we also want to stress the benefit of an in-person visit.
Okay. And any other questions? Dr. Rodriguez, I wanted to ask you one more question. You and I spoke briefly before the press conference, and I know you had some very serious concerns about people delaying getting their A1C test, which would in fact be a test that you have to get in person. It's a measure for people who have diabetes. Can you share some of those concerns?
So yes, I can. I think one of the issues that we're seeing is this, and that is that diabetes, like many other chronic conditions, are being neglected during this pandemic because we're all scared about COVID. And the bottom line is that the best way to get your resources together in the unfortunate event that you get exposed to COVID is actually to get your diabetes and your hypertension and your other chronic conditions under control. So my concern is that as we see these A1C numbers going down, what it really represents is that people's control of diabetes is going down, which means that their personal resources to maintain their health are being compromised. And so that's where we need to intervene. I'm also concerned because diabetes is one of these diseases like COVID that affects our minority populations at higher levels. We know the Pacific Islanders in the state of Utah have the highest death rate from COVID. We know the highest infection rate is among Native Americans in the state of Utah. We also know that Latinos are 24% of cases, but we're only 14% of the population. And so diabetes is the same way. Since it affects those populations at higher levels, this also becomes a health disparities moment where we are reaching out to our patients to say, listen, we understand that COVID has been bad to your population and to all of our populations. Please allow us to help do what we can to make it better. And so the invitation to come and get your diabetes care is very important, especially since, you know, we're so close. At some point, maybe in the next 2 months, this vaccine will be available to everybody who lives in this state. And we want to make sure that we can help everyone we can to be ready for that day. And part of it is getting their health in order.
Thanks, Dr. Rodriguez. Do we have any other questions before we turn it over to Spanish? If not, Dr. Vinick, I'm going to give you one final thought, and then we'll start taking questions in Spanish. Anything you'd like to add here, Dr. Vinick?
No, I just really appreciate you all coming in and getting the message out. Once again, healthcare is safe. Get your care. Doesn't matter where it is, but please, please get the care that you need. Take care of yourselves. COVID is not going to go away anytime soon, but we have to learn to live with COVID and take care of ourselves during this time.
Thanks, everyone. And we're going to take questions in Spanish now. Dr. Rodriguez will be available. I do want to also mention we'll send everybody a recording, and we'll also send you these slides that we presented today so that you have those data points. Okay, Dr. Rodriguez, so there's a question for you in the chat feature if you want to take that.
Fantastic. Francisco, could you read it to us?
Por supuesto que sí, doctor. Gracias por su tiempo. Mi pregunta es, ¿qué es lo que usted más ha notado de la comunidad hispana a la hora de realizar los chequeos? ¿Qué nos falta? ¿Qué nos falla? ¿Por qué no tenemos un doctor primario? Es algo que los latinos carecemos. ¿Cuál es su opinión? Muchas gracias.
Wow, son muchas cosas y muchas preguntas. Voy a empezar con la primera. Y es que a la hora de los chequeos, siento que nosotros como latinos tenemos un poquito de miedo. Después de todo, hemos sido azotados, atacados por este virus. Y muchos de nosotros nos hemos infectado en lugares, o sea, no sabemos cómo nos hemos infectado. Y también muchos de nosotros hemos visto que nuestros familiares, nuestros amigos se han enfermado o se han muerto de este virus. Y eso contribuye al miedo y al dolor de nuestra población. Y yo creo que eso tiene parte que ver por qué es que no estamos viendo. Otra cosa es que francamente nosotros como médicos, como dijo el doctor Vinick y otros, nosotros hemos tenido que hacer muchos cambios en este tiempo. Y al principio dijimos, no podemos ver a nadie. Y después dijimos, no, solo podemos verle por video. Y después dijimos, sí, podemos verle por video y en persona. Y ahora estamos diciendo que no importa, podemos verle en persona cuando quiera, por cualquier cosa. Entonces, ese nivel de confusión también afecta a la población latina. El mensaje de hoy tal vez no es el mensaje de ayer y tal vez no es el mensaje de mañana, pero el mensaje de hoy es sí estamos abiertos, sí queremos ayudar y sí tenemos médicos que hablan español, enfermeras que hablan español, tenemos todos los servicios en español para nuestra población. La segunda cosa es que ¿qué nos falta o qué nos falla? Pues una cosa que nos falta nos hizo en la siguiente pregunta, donde dice que no tenemos un doctor primario. Eso sí es una cosa que como población necesitamos tratar de cambiar, porque si podemos establecer una relación con una doctora o un doctor o un proveedor de cuidados primarios, eso va a ayudar para que podamos controlar nuestras condiciones. Sabemos que como latinos tenemos un porcentaje muy alto de diabetes, de obesidad, de presión alta, de colesterol. Y entonces, haciendo esa relación va a ayudar a que nosotros recibamos lo que necesitamos para mejorar. Y la otra cosa que iba a decir es esto. Muchas de las cosas que están sucediendo ahora y que estamos viendo en el COVID tienen que ver con otras cosas fuera de la salud. O sea, vamos a hablar francamente, no podemos hablar de COVID sin hablar del racismo sistémico, que es antinegro, que es anti-latino, que es anti-asiático. Y ese racismo tiene un papel aquí también. Y la invitación es que nosotros como la Universidad de Utah estamos cambiando y le invitamos a nuestros pacientes que cambien con nosotros.
Doctor, tengo otra pregunta, quizás un poco más complicada de responder, pero aquí le va. Muchas veces nos da miedo ir al doctor Rodríguez, porque tenemos miedo de que nos digan exactamente lo que no queremos escuchar, ya sea un cáncer, ya sea alguna especie de tumor, alguna incapacidad que sepamos que no debemos trabajar, pero vamos quizás hasta por necesidad. ¿Qué recomendaciones, qué perspectiva nos puede dar? ¿Cuál es su opinión? ¿Qué podemos hacer? Porque esto ocurre mucho en la comunidad hispana.
Claro, y es un miedo real y es una realidad para la mayoría de nuestra población. Voy a tratar de tomar la pregunta en partes. Primera cosa es que usted me dijo acerca de que el médico, la doctora, la proveedora de salud va a dar una información que no queremos escuchar. Eso sí es algo real. Y le voy a decir algo, especialmente cuando viene a cosas de discapacidad y de dejar de trabajar. Yo he trabajado con la población latina y con mis pacientes, cuando yo tengo que darle noticia acerca del trabajo, esa noticia siempre viene con la información de que yo voy a trabajar con ellos para preservar su trabajo. En otras palabras, los médicos no estamos tratando de discapacitar a ningún empleado. Y queremos trabajar con el empleado y con los empleadores para asegurar que nuestros pacientes puedan seguir trabajando, porque eso es sumamente importante. Ahora, las otras cosas, tumores y cosas así, eso es más problemático, porque nadie quiere escuchar malas noticias. A la vez, debemos de recordar que esa bolita, ese tumor, si vamos a la doctora cuando esa bolita es chiquita, la posibilidad de hacer algo es mucho mayor que si esperamos hasta que esa bolita sea grande. Y la mayoría de las cosas que tenemos ahora, tenemos la habilidad de detectar cáncer mucho antes de lo que teníamos cuando yo empecé la carrera hace 20 años. Y entonces, sí tenemos cosas que nos preocupan. Para mí, eso es, pues, más razón para venir a buscarnos. Porque sí podemos hacer más al principio que al final. ¿Eso contestó la pregunta?
Perfecto, doctor. Sí, se entendió muy bien. Mi última pregunta para usted, para dejarlo en libertad, es, hay miles de familias, doctor, hispanas que no tienen seguro médico. Y hay chequeos que no podemos dejar de pasar nosotros. ¿Cuáles son esas recomendaciones? Si, por ejemplo, una familia hispana batalla en conseguir una cita por horario de trabajo, por economía, etcétera, ¿cuáles son los chequeos que un hispano no debe perderse anualmente?
Ay, qué buena pregunta. Ahora, la primera cosa que tengo que decir que el problema de no tener seguro en nuestra población es también un problema relacionado con el racismo antilatino. Primera cosa. Segunda cosa que puedo decir es que si una persona no tiene seguro, sí hay lugares donde uno puede conseguir cuidado económico. Aquí en la Universidad de Utah, si vienen a nuestra clínica, sí hay lo que se llama un sliding scale, que quiere decir que paga un poquito cuando llega y después trabajan con la paciente para que ella o él paguen lo que puedan después. Pero también hay centros de salud comunitarios que se llaman Community Health Centers, que también tienen dinero del gobierno federal para proveer ese tipo de salud, ese tipo de cuidado de salud. La otra cosa es que nosotros debemos de recordar que eso de sacar sangre todos los años tal vez no es muy necesario. Pero si es que tenemos antecedentes familiares. Por ejemplo, yo tengo pues hermanos, mi hermana mayor, mi hermano menor. Ellos, los dos tienen diabetes. Eso quiere decir que yo debo chequear cada año para diabetes. Tengo familiares que se han muerto de cáncer de colon. Eso quiere decir que la recomendación es que cuando yo tenga 50 años, que yo saque mi colonoscopía. Ahora, cumplí 51 años hace una semana, justo hoy, hace 8 días. Y yo tenía mi colonoscopía programado para marzo del año pasado y se canceló por la pandemia. Así que a mí me toca hacer lo mismo. Así que si yo estoy hablando de 4 cosas que se deben hacer, sería mamografía para toda mujer que tenga mayor que 50 años, Papa Nicolau cada 3 años para cada mujer que tenga más que 21 años y que esté activa sexualmente. Papa Nicolau, mamografía, colonoscopía después de 50. Y la otra es chequear para la diabetes, especialmente si hay antecedentes en la familia. Lo que yo estoy viendo es que hay mucha gente que están saliendo con diabetes entre 20 y 30 años, que es una cosa que no se veía hace 20 años. Así que esos son los 4. Hay más, pero yo empezaría ahí. Y yo buscaría centro de salud comunitario o que venga donde nosotros en el Redwood o en otras clínicas que tiene la Universidad de Utah, porque sí podemos atenderlos aún sin seguro. No va a ser gratis, pero se puede atender.
Hay maneras de trabajar los pagos, ¿correcto?
Claro, siempre hay.
Muy bien. Pues no le robo más su tiempo. Gracias por su espacio. Hoy lo corremos en el noticiero 5 y 10.
Gracias, siempre es un gusto hablar con usted, Francisco. Cuídese.
Un gustazo. Estamos en contacto. Gracias. Bye bye.